you know, sort of the issues about who owns these data and what they're used for is it's a problem for all the metrics we talked about, but it's a bigger issue for cost metrics than anything else. And that's a policy issue. You know, and the final point I'll make is that it's also related to the governance, because the all-payer claims databases, they get you past a lot of the policy issues, but I managed New Jersey's all-payer claims database, and when you're in the government, there's certain things you can't do that can be harder to do too. So sort of lots of issues about who controls it, what the politics are, national versus local, public versus private. Harder, I think, in this area than any other one.
So great point. And so there was some discussion, and I know Peter had a thought on that there may be a few things where we need policy or even dare say regulation or clarification, such as antitrust. A lot of us have gone through this, and so we could get clarification from the FTC on, okay, what is in the bounds of antitrust and what isn't. You know, correct me if I'm wrong, but you know what we find is that when the state steps in and mandates the claims data from the payers, you get an all-payer database, but then it's very hard to do the kind of measure. I'm not sure why, but the measurement doesn't happen. Then you have the collaboratives, and they're able to do the measurement, but they don't have the data. So yes, policy, regulation, it may have to be a quasi-public-private entity within a state, and with some combination of regulation and such, and ground rules.
Tom, though, let me ask you along those lines. Don't you see quite a bit of variability across the country when states, for instance, require reporting the data on its available use? So the rules in Minnesota, the rules in Vermont are quite different. So I don't know that it's de facto that it has to turn out that way. That may just be a part of a cultural evolution.
Very broad generalization,
So question about the safety net and especially uncompensated care. When I heard you describe the range of costs you're attributing to the healthcare system, they seem claims attributable costs in a standard framework. And I'm wondering about these other costs that actually have other ways of being paid for, but they're not through a claims frame and sort of globally are called uncompensated care.
And you know, we didn't discuss that, but obviously that's a great question. And if there's, I don't know, how many uninsured now? 30 million, 50 million? So that's a big, giant, dark spot. Hopefully as the ACA rolls in and more people have insurance, we'll have more claims data, but we did not address that issue.
So as someone that did work in this, the data with EHRs is now there. So the utilization data is captured systematically in the same way. It's just not sent to anybody. It's kept locally. And so it's actually possible to attribute a relative charge to things that never were billed because we know that they happened. It's just not sent in to a
So I'm sure there's a solution there, and we didn't address it.
This would be a good topic for the implementation and the infrastructure discussion, I think.
Actually, we did sort of speak to it in the segregating the data so that we could see where cost shifts occurred, and I was thinking when that comment was made that cost shifts related to the uncompensated care that is being shifted in one way or another. That may not have been what was intended by the comment, but we did have some comment.
George, you have to sort that one out.
So I think about the reason we have the triple aim, and it has a cost, per capita cost component in it, is because we have a cost problem in the country. And if other societies may or may not have that, you know, as part of that. So since we're thinking about triple aim, at the end of the health work group session, we started talking about specific targets. And Pat, you know, mentioned that. And Carolyn Clancy, and I was looking around to see if she was still here. She is there. Mentioned the fact that one of the things on the table, and if I've got this wrong, jump up and tell me, for what may happen next year is $600 billion in. That's
a counter offer now.
Right. So that's in play. And then we had a little bit of interplay, which we really didn't have a chance to really talk about, in terms of the fact whether that actually would be waste, the 750 billion estimate that I think your roundtable has done previously a couple years ago, or whether it would just be cut, cut. And so it becomes a big policy problem. And so we were thinking in the health group that we ought to be setting specific targets and creating conversation about how you get to that big figure of whatever it is. And so if you picked 750 billion, then what kind of measures would be interesting to think about? And we didn't really have a chance to talk about this, but if you look at across the states and you look at per state data, you see a lot of variation in terms of where that level lies. And so Matt Stifel is here. Matt, are you here someplace? Yeah, you mentioned that in the UK, there's actually some kind of measure by small postal code for looking at variance in cost and trying to figure out, So I know that's a little bit out of the framework of thinking, a little bit out of the way we set up the conversation. But it seems to me, one, we ought to have a national conversation about setting those targets and then figuring out how you get there. And then what is the situation or the challenge by locality across the country, by state, by community, in terms of average costs? And what measures would we use, across the triple aim or in particular across cost to sort of get to that variance kind of thing? And then how could that set up activity that gives an alternative to the 600 billion, in cuts, that might be looked at in terms of waste. So one thing I did, kind of flip off the top of my head was during that was, that would be a great topic for an IOM study.
Mm-hmm. Yeah.
And so I'll say it here on the record.
Well, I don't know if anyone else wants to respond. We did not talk about targets. But those conversations are happening all over the country. In California, should it be CPI plus X? And obviously, the 600 million or 800 billion or whatever the number is, that's government spend. But we also have the private sector. So, I think it would be, targets are good. They focus people, but we didn't talk about it. Dennis, yeah.
I guess I would just add that, I think we talked about the components of cost, and of course, when people say cost, typically within spending, and we talked about all the different definitional terms that come under that. But at the local level, you've got to drill down to a solution, and the solutions are, like Randy said, you can focus on overuse, you can focus on waste, you can focus on things that really shouldn't happen and they have low marginal value. You can focus on price and variation in price at a local level, which you may or may not be able to do something about over the short term, depending on market concentration and supply issues and that sort of thing. And then I think we didn't talk much about, but we did acknowledge that there's also this whole other production side, which is, can you more efficiently combine inputs to achieve outputs? And that's probably something that would overlap with the healthcare group. Team-based care relative to status quo producing a visit for inpatient hospitalization and post-acute care for somebody with an AMI. There are different ways to take resources and combine those inputs and produce outputs differently than we're doing in some efficiency gain.
Thank you. Well, this has been a great discussion. Thank everybody for the inputs and the questions and the comments, and to our reporters out of each of the groups. This was a tough task. It followed what was really an interesting day around laying out a vision and what the state of measurement is, and some great examples of things that are being done and progress around the country. The challenge of then stepping into a group and asking, are there core measures that you can measure across, or you would start with, examples you would start with across all settings that may not be as sophisticated everywhere, was obviously a tremendous challenge. And we certainly got a lot of discussion around the characteristics and the categories, and some around some specific examples and measures. And I just want to thank everybody for the intensive input and sticking it out through a long day. The reward at the end of that is a nice reception, I think, that's being held in the dining room down the hall from 5:30 till 6:30, and then there'll be buses to take you back to the Fairmont Hotel at 6:30. But before we do that, I think I would thank our hosts again, Michael, and see if you have closing comments for the day. Thank you.
Well, now that you've announced that I'm between the group and the drinks, I'll be extremely brief, I can guarantee you. I'll start where I started this morning with a thank you to each of you. This has been really a very enriching day. The presentations this morning and this afternoon were very rich. The discussions were wide-ranging and stimulating, really energizing in a variety of ways. A number of big-ticket questions were touched on. First, the issue of what measures are most meaningful and to whom. The issue of what meaningful measures will trigger the most local adaptive action, whether it's local at the community or local institutional level, that will allow for that flexibility and empowerment at those levels. The issue of what's most actionable in many ways, and of course the related issue of what's actionable by whom. Who's accountable? Are we imagining that these are metrics for which the community writ large is accountable, or are we imagining that it's an accountable care organization, an entity that has the ability to shift resources in one fashion or another and actually tweak the levers, whether they're levers that are directly or indirectly engaging the major influences on the measure outcomes. We also teed up the issue of how we consider the interface of the metrics that are identified with the requirements of various government programs and other payers and individuals and stakeholders in the mix. Clearly, we want metrics that will help automatically to meet those requirements, or conversely, maybe even metrics that are so compelling that those requirements can be reduced substantially in order to allow that kind of flexibility. And then we heard teed up the question of what metric strategies will be most supportive of the kind of continuous real-time learning that we have as possibilities and that we want to move toward, so that we're not getting reports 2 years or 2 months or even 2 weeks down the line. These are all important questions that will have to be considered as we move forward. There are, I would remind, 2 differences in this workshop and the way we conduct most workshops that are relevant for moving forward. The first is that we will leave the record open for a longer period of time so that the folks in the work groups can massage the framework that actually moves out in a reported fashion, and you'll feel a greater measure of comfort with what emerges in that respect. And the second is that we're setting the stage for follow-up activity. So what I would ask you to do, and we'll come back to this issue at some other point, is to imagine that you were, and in fact it's not just a question of imagining, you really are in many ways, writing the scope of work for a follow-on activity. And what would you see as the most important elements, the key elements to include in that scope of work? What are the key not key, what are the dimensions that you would specifically leave out of that scope of work? And what processes would you build in to an effort to help us extend the really remarkable foundation that's already, even in this first day, been developed? We will return to the kinds of discussions that we've just had in tomorrow's session, which is focused on implementation issues and the infrastructure involved, but we obviously can't deal with implementation and infrastructure without raising again the notion of the categories of metrics that have been identified. Rob and Julia and Valerie and Barrett will be working all night No, they won't. This is not they're not to create the full set of measures, but they will try to capture the categories that were teed up by your working group so that you'll have them available as reference points throughout tomorrow's discussion, which I think will be really a terrific discussion. So I will stop so we can go have a drink. But again, with a very strong note of thanks to each of you, to our speakers, panelists, chairs, reporters, and to the staff for great work.
Thank you, Michael. Thank you. Thank you, everybody.